really interesting situation. He's dealing with spondylolisthesis with stenosis. It's really a classic indication for spine surgery. Unfortunately, once the hole's too small, there's the only thing that can make a small hole bigger is surgery. I hear that notion a lot, that chiropractic can change the bones, and that's 100% not true. I would challenge anyone in America who believes that is true, who's watching this, show me an X-ray of where you had spondylolisthesis and then you had chiropractic care and it reduced it. I'd love to be proven wrong by this, but I've never seen such an X-ray. In my own experience with the spine, it's just not physically remotely possible. So I just don't, I mean, I would have to, seeing is believing, right? And it would be great if I were wrong. If there was some chiropractic school that could fix that without surgery, then by all means, let's fix it that way. But I don't think that's true. You know, I have to say, there's good and bad in everything. And let's face it, in everyone, right? I've met some of the most talented people I've ever met in my life were doctors, neurosurgeons in particular. But I've also met some that I thought were not so credible and not so great. So there's a range. There's these really talented and good people, and there's people who are not necessarily like that. That's really true in chiropractic as well. And chiropractors, there's some just amazing doctors out there. There's some people who I would trust with my spine, I would trust with my family, just great healers and really awesome individuals. But there's a lot of crooks. And I'm sorry, but there's just no other way to say it. There's a lot of people who have gotten into ideas that they're not qualified to act on, and they propagate misinformation, like they can reduce spondylolisthesis or they can get a herniated disc to go back in. That's just not true. And so be wary. One of our goals here on Best Practice Live and Best Practice is to make sure you don't succumb to this information and you don't get into this stuff. So we definitely interested in talking about it. All right, listen, I'm sorry we got interrupted. I was trying to go over another really important thing, and that is cost. Look, your financial health is part of your health. And if a treatment is going to put a lot of stress on you financially, and it very well may, then we need to be able to talk about that. You need to be able to talk to your providers about that. I found as a doctor that people are often really, really shy about this issue. They don't want to talk about it. Listen, you just heard David. We're talking to people about constipation, erectile dysfunction, rashes. We're talking to people about the most intimate issues in their lives. For goodness sakes, you can talk to us about money. Doctors are more than able to talk to you about it. Now, some may not have that discussion with patients, but they'll tell you who does in their office. They'll tell you exactly who does. And if they make you feel ashamed or embarrassed, you're at the wrong doctor. And frankly, I don't think that's going to happen. It's just you gotta get over that. But let me show you another way, because it is very complicated, these issues with insurance. And I want to show you, Delphina's question was, I need neck surgery. How much will it cost me? And this is such a common question that we actually put on our website, a way to figure that out. Let's go to the screen. Now, this is the Phoenix Spine and Joint website. And first, let me go to the home page so you see where we are. This is the clinic, the in-show we used to do. Here's some doctors, here's some insurance, here's the location of some surgery centers. Now we're going to go to resources, insurance, and then Aetna, Cigna, Medicare, or United Health. Let's say, I don't know what Delphina has, but let's say she has United Health. So I'm going to click on that. United Healthcare Insurance accepted. United Healthcare. Accepted, by the way, means that Phoenix Spine and Joint is in their network, the surgery centers. Phoenix Spine and Joint can help determine if your plan will cover your procedure and estimate your out-of-pocket cost. Start by finding a surgeon. Procedure. Delphina needs neck surgery, that's ACDF. And I'm going to put her in our I don't know where she lives, but let's put Gilbert, and she has United Healthcare. So the surgeon out there would be Dr. Raf Beg, really awesome orthopedic, fellowship-trained orthopedic spine surgeon who has enormous experience doing ACDF surgery. I'd let him operate on me, really great surgeon. Well, but how much is the surgery center going to cost? Now, keep in mind that the surgery center is not the doctor, right? There's going to be a separate calculation for the doctor. But let's talk about the surgery center. So the first thing is, what's my policy deductible? I don't know, but let's say Delphina has a $5,000 deductible. Deductible already met. Let's say so far this year she's paid out $4,000. So she's got out-of-pocket max. The out-of-pocket max is on your insurance policy the most that you can be expected to pay out of your own money in any given year. So that's not just the deductible. That's also the co-insurance. And let's say her out-of-pocket max is $6,000. Out-of-pocket max already met is also $4,000 because she's still under her deductible. And her co-insurance, what percent does she have to pay? Most of the time, it's a lot of plans are 80-20, where the insurance pays 80% and the patient pays 20% up to their out-of-pocket max. So how much is that going to cost? The out-of-pocket cost for the surgery center is $2,000. Boom. Now you know. That's how much the surgery center is going to cost you. The doctor's going to be a little bit more. The anesthesiologist is going to be a little bit more. So you are going to, and any expenses that you have related to getting medical clearance, like if Delphina, I don't know, let's say she has a heart condition, she has to get a cardiac stress test. That would all go against her deductible, but that's there as well. So anyway, that's how you use that calculator, Delphina. I hope this helped and that we got you the answer to your question. Okay, the second thing I wanted to do today was follow up on a question that we had from YouTube yesterday, and that was from Rich RZ. Rich talked about, if you remember yesterday, we talked about Rich and his sciatica due to a herniated disc. He'd had an MRI, he tried water therapy, he was thinking about getting an epidural injection, but thought he'd wait to 12 weeks. And I recommended Rich, hey, pull the trigger now. If you're gonna get an epidural, you need it now more than ever. And so Rich responded yesterday on YouTube, and I wanted to show that to you guys. I'm actually now, from this video, considering the epidural at 7 weeks. Okay, I've had sciatica since January. God, that's too long. I'm so sorry. I mean, that's 9 months of pain shooting down your leg. That's just awful. But they had me treating as if piriformis until the MRI in August when it was exacerbated. Okay, look, guys. Rich went from January till August. Remember, and he was mislabeled as having the Piriformis Syndrome because he had sciatica, which is pain down the leg. We're going to talk about Piriformis Syndrome in a minute, but what finally got them on the right track was the MRI. For someone whose pain is primarily in the leg, do you remember from yesterday when Rich should have had the MRI in the normal sequence of care, in the optimal sequence of care? 3 to 6 weeks. That was in January. This 9 months, or he had it in August. 8 months of suffering was not necessary. That's you gotta know what to expect. And I wasn't there. I'm not pointing at anybody and calling anybody out, but you have to help your doctor get you the right care. And if Rich had seen this video in January, he could have said to his doctor, hey doc, don't you think it's time for an MRI? Because I have sciatic pain. It hasn't responded to 3 weeks of conservative care, even though I don't have any red flags. But what do you think about an MRI? And the doctor would have said, yeah, Rich, that's probably a good idea. Let's go ahead and get that done. So that would have short-circuited. That interaction, had it occurred, could have avoided 9 months of pain. So people sometimes say, hey, why are you doing this daily show? That's why. Like, I don't want you to suffer. That's to me, the thought of this guy having this wicked pain every day for 9 months. I mean, it's heartbreaking for no reason, right? The MRI scanner was invented 20 years ago. It's been here. He could have just had the scan. So I don't know, it bugs me. But I'm glad he's on the right track now. And I don't want this to happen to anybody else. So I want to talk to you guys about this thing called the Piriformis Syndrome. It's fascinating, actually. Let me go to our buddy, the spine model. I should find a name for him. But he's, because he's getting used so much. So here's the spine. And this guy is now facing you in the same way that I'm facing you. So I'm at his bum, and his head is up there. This is the lumbar spine down here, and so I'm going to turn him around so that he's facing now backwards, and I'm facing you forwards. And I want to point out the lumbar spine are these bottom 1, 2, 3, 4, 5 levels. These are the spinous processes, which are the bumps you can feel in someone's back. And then we come down to the sacrum. And if you look around from the sacrum, we're in the pelvis. And this part of the pelvis has a notch. See how it comes up and forms a notch right there? That is called the sciatic notch right there. And I want you to take a good look at this view. Now imagine the next picture I'm going to show you is a blow up of just this area. So we've got the sciatic notch in there and the sacrum and the ischium, the bone coming out this way. The sciatic nerve is made up of these nerve roots here, but they then come together and form a nerve, which we're going to see in yellow is coming out here and then going down the leg. Now, let's go to the screen and have a look. Now, remember, here is the outside of the pelvis, and here is the sacrum, and this is that sciatic notch, see right there, that we just looked at. This is a muscle that goes across, and this is the sciatic nerve coming out of that area. So this is irritation of this nerve is what they call sciatica, but this muscle has a name also. It's called the piriformis muscle. The piriformis muscle. Any guess why they called it that? See the shape, like if this was a pyramid, here's the base, and here's the tip top. So it's kind of, and if you could see it in 3 dimensions, it looks even more like a pyramid. So this is the piriformis muscle as it relates to the sciatic nerve. And it's real interesting because in theory, where that sciatic nerve comes through the notch, if the piriformis muscle is constantly in spasm, the sciatic nerve can become trapped in that location, and you can get sciatica from entrapment of the nerve in the sciatic notch. It sounds a little crazy, right? But what about, and this is a very uncommon condition, but think about carpal tunnel syndrome. If you've ever had burning in your hand at night, you wake up and have to hang it down and shake it. Carpal tunnel syndrome, very common. That's from entrapment of your median nerve at the wrist in the carpal tunnel. Tarsal tunnel syndrome, numbness in the foot due to entrapment of the nerve there in the ankle, is also a similar phenomenon. So there are these entrapment, ulnar, you can get an ulnar nerve. Some of you may have had a relative or even yourselves who've dealt with that. So nerve entrapment is not by any means impossible, but sciatic nerve entrapment in the sciatic notch by the piriformis muscle is extremely rare. In my spine career, I don't know if it was 20,000 people I saw. I mean, it was a lot. I could count on one hand the number of people who turned out to have piriformis syndrome. You read this stuff that 15% of back pain is due to piriformis syndrome. It's not. It's not even remotely anything like that. But it happens. It's very rare, but it does happen. And let me tell you how it happens. Let me tell you how you diagnose it. So first, I would recommend you get an MRI of the spine and make sure there's not something else. So Rich RZ, if they would said, hey, 3 in 20,000 people had piriformis syndrome, but 8 out of 10 people get back problems, let's just check an MRI. They would have seen that herniated disc and figured out that it wasn't piriformis syndrome. So number one, get an MRI and make sure there's not something much more common happening in the lumbar spine. Number two, if they tell you you have Piriformis syndrome, is get on physical examination. If you have Piriformis syndrome, if you push on the sciatic notch, you should get immediate sciatica. And it's dramatic when it happens. You take my thumb, put it on their bum, so get to the sciatic notch, boom, push, sciatica, relax, gone. Push, sciatica, relax, gone. You can make it happen just by pushing. And of course you don't want it hurts, so you gotta be, you're not trying to hurt people, of course, but it's not subtle. Now, when you push on someone's bum like that, on their sciatic nerve, you're not doing anything to the lumbar spine. So if that causes if you push in the piriform fossa along the piriformis muscle and you're causing the sciatic pain, that's a strong indication. And then the last thing is you can know from your own history, okay, if it's the sciatic nerve that's impinged, what's the involvement of your back? None. So there should be no back pain. Whereas you can get no back pain and just pure sciatic pain from a spine problem. Most of the time there's some component of backache and it's associated with the radiating pain. So if there's zero, that doesn't mean it's piriformis, but it could be. Well, these are some ways that I hope you can avoid being misdiagnosed and suffering for 8 months in this case. I hope this helps, and if you are ever told you have Piriformis syndrome or somebody you love is told they have Piriformis syndrome, please come back and watch this. It's crucial, it's a very rare condition, and yet I guarantee you here in Phoenix where I am, it's being misdiagnosed all over town today. So don't let that happen to you. More good advice from best practice, more good advice. All right, that's follow-up on Rich RZ. I also want to talk to you today about total knee replacement. One of the most common questions that people ask is, well, when is the pain going to go away? And it's not a surprising question because the reason you have surgery, in theory, is you have severe osteoarthritis or rheumatoid arthritis or avascular necrosis or as a result of changes from a fracture, but vast majority are osteoarthritis, and you need to get that corrected. But what drove you to the surgery was the pain. I don't know if you remember when we were talking to Vicky Cam yesterday, why'd you decide to do it? It just hurt so much. I couldn't do anything. I want to be more active, and so I want to get out and play with those goats with my granddaughter. I love that. But it's the pain that drives us into surgery, not anything else. If it didn't hurt, even if the x-ray looked horrendous, there's really no reason to have surgery, right? Unless there's a deformity that's making something else worse. But anyway, it's the pain. So a very legitimate question is, well, when's the pain going to go away? Well, we got some really good data on that I wanted to share with you. Let's hit the screen and take a look. At Phoenix Spine and Joint in the second quarter of this year, we did about 100 joint replacements. And, let me go to the next one, yeah. And we ask everybody, how'd you do? We get feedback from them. And we just yesterday got the report on the patients from Q2. So that's April, May, and June. And because, now we're at the end of September, so we found out how they did 3 months later. And what we found out was before surgery, the percentage of patients who had mild or no pain, before surgery, small percentage, 24% are at best. But 6 weeks after surgery, it's 80%. And 3 months after surgery, it's nearly everybody, 92%. So long story short, how long if you have a knee replacement until you have no pain? You have an 80% chance your pain is going to be all the way gone, pain-free, or almost entirely gone by 6 weeks. And then you have a 92% chance that it's going to be either completely gone or nearly completely gone by 12 weeks, which is 3 months. So that's really important, I think. A really important thing to know. Look, if you look in the medical literature at total knee replacement, there's dozen studies where they've asked a group of people, 100 people, 1,000 people, 10,000 people. Hey, are you glad you had surgery and would you do it again? And how much pain are you in is obviously the main thing that drives that. For total hip surgery, that number is 92%. So it's a very, very good number. But for total knee surgery, that number is like 74%. That means like 26, 27%. 1 in 5 people aren't glad they did the surgery. That's a huge number. Now, I guarantee you, if you're 92% of you are pain-free or almost pain-free by 12 weeks, those doctors are not getting 26% of their patients sorry that they did it. Why? Well, all the doctors who operate in the surgery centers here use a robotic assistant. That's huge. They do minimally invasive approaches, gets you back quickly. They do it in an outpatient center. We're outpatient, not hospital. So it's safer. You're much less likely to have a complication like infection or hospital error, which is going to, give you problems and make you sorry that you did it. So, and I can just tell you, our surgeons are experienced, and all they do are minimally invasive approaches, and they do hundreds of them every year. That's how you get good. When you're doing something over and over and over, you really find out how well it can be done. I am stunned at the number of people who go to surgeons who are not highly experienced. And I actually want to show you in our next, let's go back to the board here. I want to get there. Low volume orthopedic. So this was from a study that came out in the Journal of Arthroplasty, which is the world's premier journal on hip and knee and shoulder replacement. And it came out in May, so it's a couple months old now. Low volume orthopedic surgeons with higher rates of complications perform 88% of total knee replacements and 93% of total hip replacements. Okay, I'm sorry, I just got to say this again. Low volume orthopedic surgeons, that's surgeons who don't do more than, I think in this study it was 50 per year, with higher rates of complications perform 88% of total knee replacements, 93% of total hip replacements. Look, ladies and gentlemen, this is on you. I'm sorry, but this is on you. Like, let's think about this. We have known for 20 years that the probability of having a complication in joint replacement surgery is much higher, double the incidence of death, double or more the incidence of infection. All these rates are much higher in surgeons who don't do a lot of surgeries. If you're 88% of you, oh, by the way, this study actually looked at the Medicare database and said, okay, how much experience, as the experience goes up, the complications go down. Where does it stop going down? Like, how many do you have to do a year before you don't get any better? And it turned out the number was 260 hips and 260 knees. So you need someone who's doing 5 to 10 of these joints a week, of each joint a week. So now the surgeon, so please tell me, why are 88% of you going to someone who does one of these a month? When the good surgeon, you get better and better and better until you're doing 5 to 10 a week. It's undisputed. It's a fact. This is not, you may love your surgeon. Dr. Jones may be the nicest guy. Let's call him Dr. Dan. He may be the nicest guy, and his office manager bakes cookies. And whenever you've needed an injection for your knee over the last 5 years, you've just gone in and Dr. Dan took care of you, and the office manager gave you the best chocolate chip cookie you'd ever had. That doesn't make Dr. Dan a good joint replacement surgeon. That makes Dr. Dan a nice guy and a good person and they're running a good business because you feel comfortable going there. But none of that has anything to do with how good a surgeon Dr. Dan is. What makes Dr. Dan a good surgeon? He uses a robotic assistant. He operates in an ambulatory surgery center or a hospital with a hospital compare proven lower rate of complications. He does a large volume of these operations, turns out more than 260 a year. He does a minimally invasive approach. Now, he can't operate in an ambulatory center unless he does that, so that was actually a given, but that's the case. And then he uses registry implants. Now, those are the 5 things that make Dr. Dan a good surgeon and the one you should go to. On-time scheduling for your office, not one of them. Office manager bakes the best peanut butter cookies you've ever tasted, not one of them. Kind and did a good job on your neighbor, uncle, cousin, whoever. Everybody does a good job once in a while, right? That doesn't mean they have the lowest possible chance of complications. So don't pick your surgeon, people, based on these other things. It seems intuitive. One I hear a lot is I vibe with him. You know, I got a good feeling from him or her. It's really nice, but frankly, I want someone who cuts straight and cares less. I mean, I hope I can get a good feeling from this guy or this lady because they're good. But if I don't, I'm still going to them. I'm still going to them because they're better. They're numerically better. And it's your life. With these joint replacement surgeries, you only get one chance to do it right the first time. You really, really, really want to make sure you load the deck in your favor, stack the deck in your favor. Go to a surgeon who gives you the best chance of having a good result. And that's somebody who meets this checklist. Now, how are you going to remember all this stuff? You know, you're hearing this, and how are you even going to know? The way is go to our video where I provide you with a checklist for how to find the right joint replacement surgeon. If it's hips, then that video is on hipreplacement.org, or I'm sorry, hip-replacement.info. If it's knee, it's on Phoenix Spine and Joint. Search us on Facebook. Go to our Facebook page. We publish this. We put this graphic out with a checklist for your joint replacement surgeon. If you're just like, I don't know, like I just can't do it, it's too much for me, then just call us. We can handle it. We interview these surgeons. We can find somebody for you who meets all of these criteria and is going to do a really good job on your joint and is going to do it right the first time because they do it right every time. Well, it's Friday. I'll be hitting the omega. I'll be hitting the flaxseed oil, gigantic brown pills myself this weekend, trying to feel better. I hope you feel good. I hope you're doing as well as you can. If you're not, please give us a call. We're here for you. We want to help. It's my job now, and I'm looking forward to hearing from you soon. Have a great weekend. And if you want to get more content like this and keep up with us, please click through the link to our website and sign up for Best Practice Live. Join our team. Join the informed people who are not going to suffer for 8 months because some crazy chiropractor misdiagnosed their Piriformis Syndrome. Get hooked up with the best doctors, many of whom are chiropractors, and understand your condition so that you can take it to the next level and get rid of it. For Best Practice, I'm Dr. Dan Lieberman. Have a great weekend, and I'll see you soon.